Hello class, welcome back to another lecture. Today I'm feeling a little bit under the weather, so that's why my voice sounds like this, but we're still gonna get it done. Today we actually have an additional special guest. So firstly we have Landon, my husband, obviously, give it up for Landon. But as our secondary special guest slash pseudo student, we have the one, the only, Mike Shapinski. Give it up for Mike, yeah! Thanks for being here, Mike. All right. So let's get this lecture rolling. Last time during class, we discussed the anatomy of the respiratory system. So when we start with air, how does that air get through our body to our lungs? And we did the whole pathway of that. So we're going to give some brief review of that. So Mike, if you don't know, it's okay because you were in the lecture. But if you do, feel free to respond. So we'll do a few review questions and then we'll get rolling in today's lecture. So let me start the timer. All right, what is the name for the back of the throat?
The pharyngeal space.
Yes. Okay, what's the name for the back of the throat?
The pharyngeal space.
Yes,
also
also
the oropharynx.
The pharynx, yes, the back of the throat, just called the pharynx. What is this arrow pointing toward?
Ooh, that's the hard palate.
It's the very back part. It's the thing that hangs down in your throat. Do you know what that is, Mr. Shapinski? Stress. When you say ah, and there's like that thing in the back. Do you know what it's called? It's with the U.
Uvula.
Yeah, the uvula. Let's go. Uvula. Totally. And to the left or right of that, we have the tonsils, right? So we're gonna ask that question. What is the respiratory structure that houses our vocal cords, which allow us to speak? It's like pharynx, but it starts with a different letter.
Larynx.
Larynx is correct. Nice. Larynx. All right. What is the structure that protects the larynx? You can give the technical term, or it's this structure right here.
Adam's apple.
Adam's apple, Mr. S. Landon, do you know the technical term for that?
Thyroid cartilage.
Thyroid cartilage, totally. That protects our larynx, where our vocal cords are housed. What is the trachea?
The windpipe.
Yeah, the windpipe. Yeah, so like where air comes down, that's eventually will break into our two bronchi, the bronchioles, into our lungs. So yeah, our windpipe. What is the unique feature of the trachea that keeps it permanently open?
Cartilage.
Yeah, totally. So we have like these cartilage rings that actually surround the tube of the trachea so that, say if we went to lay down and fall asleep, the trachea is not just going to collapse on us and we won't be able to breathe. So these cartilage rings ensure that it's permanently held open. How many lobes do our lungs have? Do you have any guesses, Mr. S?
2.
Yes, one of our lungs has 2 lobes. Landon, do you know which one?
The left lung.
Our left lung has 2 lobes, and our right lung has
3 lobes.
3 lobes. So the question is, why don't they have the same number of lobes? Why does our left lung have a different number of lobes than the right lung? Can you think of any reason why that might be, Mr. S?
Filtration.
Good guess. That's not why.
It's because the heart's there, so it needs space for it.
The heart is a little bit shifted to the left, even though it's really central. The apex of the heart actually reaches toward the left, so the left lung is actually smaller than the right lung. Do you guys remember where the place of gas exchange happens in the lungs? It's the most important place of the lungs because it's actually where we're taking oxygen, putting it into the blood, and then removing that carbon dioxide from the blood.
Catalyst.
Good guess. No, but I like that word.
Alveoli.
The alveoli. So these are these balloon-like sacs that blow up when we breathe in, and that's where oxygen and carbon dioxide are exchanged. Totally. All right. What is our main, last question, what's our main respiratory muscle called? A lot of people say sing from your, starts with a D.
Duodenum.
That's a part of our small intestine, so that's a really good guess.
Diaphragm.
Your diaphragm, like sing from your diaphragm. So that's this muscle right here that's dome shaped when it's at rest. Take a breath in, it actually goes the other way, it inverts. Cool. All right, so I have a question for you. The main concepts that we're gonna go through over today to talk about the mechanism of breathing in our body actually talks about some other concepts that we need to begin with. So let's say I took this like very fancy Dolce & Gabbana perfume and I sprayed it up here. Would you anticipate the people in the front row smelling it before the people in the back row?
Why no?
What?
No.
Why?
Doesn't make sense.
The people in the front row wouldn't smell the perfume before the people in the back
No,
row?
they would smell it before the people in the back row.
Yeah, the people in the front row would smell it before the people in the back row. And this is because of the principle of diffusion. So what is diffusion? If you just put it in your own words.
Diffusion is a particle moving across a space or a barrier.
Okay, yes. And do we know like what the concentration levels are for diffusion to happen?
Diffusion moves from a place of higher concentration to lower concentration.
Exactly. So we've talked about this before, especially when we were talking about the colon and how it absorbs water. So diffusion is the movement of particles where there are many particles to where there are fewer particles. So that's why the people in the front row would smell the perfume before the people in the back row, right? Because we're going from, like Landon said, a high concentration of particles to low. Because that's passive transport. Because what we're trying to do is we're trying to reach a state of what? Starts with an E.
I can only think of equilibrium.
Equilibrium, Mr. S, yes! We're trying to equal out the particles across space. So that's why diffusion happens. We're going from high to low concentration. Exactly. Now, this is a really important concept when we're going to be talking about gas exchange. So, in the first thing is we're just going to talk about two main concepts of gas exchange. This first one is gas moves from an area of high pressure to low pressure. Now, we know this intuitively in our day-to-day life. Because let's say, Mr. S, if I handed you this big bag of chips here that's like super inflated, what would you expect to happen when you open it up?
Release of the contents.
Yeah, you'd have this big puff of air in your face when you open it, maybe chips even, right? Because we know intuitively that gas goes from high pressure to then low pressure that's in the atmosphere. Or we know this when we shake up a can, like a Coca-Cola, or like Landon's favorite, to Dr. Pepper. If I were to shake that up, I'm increasing the pressure within the can or the bottle. So when I open it up, it's going to explode out onto my face. So the question then is, if we're moving from a high pressure concentration to low pressure, what is pressure? Like, how would you guys define that?
It's a force.
It's a force for sure. So pressure, if we're just putting it simply, it's the force exerted when gas particles collide with the walls of a container or a surface. And to be more specific, it's over a specific surface area that we would be testing it, but you don't really need to know that part. I just didn't want to make Mr. Beaver mad in physics class, so I had to include that. But essentially, look, check this out. All of these little dots in this GIF up here are representative of a gas particle, and they're moving, they're super fast moving. Every time they hit a wall, they're exerting force on the wall, and that's actually the pressure that's building up, like in the Lay's bag. The molecules of that gas inside of the bag are pushing against the bag, so when we open it up, we see that pressure release. So we'll talk about this more. So our second concept to deal with now, our first one was that gas travels from high pressure to low pressure. Our new one, our second one, is pressure and volume have an inverse relationship. So what does this mean? Can you guys put this in your own words? What does it mean that pressure and volume have an inverse relationship to each other?
So the more gas you put into a smaller area, the higher the pressure will be.
Yes. So like Mr. S, he brought up an example. If you have a smaller volume or a smaller space, then the pressure within that space will increase because they're opposite to each other, they're inverse. So another way to say this, and shout out to physics again, hey Mr. Beaver, the other side of this wall. This is because of something called Boyle's law. So the scientist Boyle, he took this J tube and he put mercury in it, and he saw it, the atmospheric pressure move the mercury in the tube. That's why we, what do you call that? The units of pressure are millimeters of mercury, right? Because of Boyle. That's why. But he may put this into an equation that you may use in physics. So we're just connecting the concepts. If you know physics, you can connect it. But that's the P1V1. So the initial pressure and volume will equal the later pressure and volume. So we don't need to go deep into that. But if you're in physics, this will kind of help you apply that concept. But another way to say this, to make it even easier, is as volume increases, pressure will what? Decrease, exactly. And as volume decreases, pressure will what? Increase, exactly. So we're seeing that happen in both of these gifts. So first, the little particles of gas start out in two separate containers. So they have a smaller volume. You see that they're hitting the walls a lot more when they're in the smaller volume cans. Then when this divider gets broken, you see less hits on the outside of the walls, and it almost looks like the particles slow down. So you see that there's this decrease of pressure there. Or up here, you have a canister filled with gas particles, and the pressure is 100 kPa. But as you decrease the volume, that pressure increases to 200. So I have a question for you then. What would happen if I pulled the back of the barrel of a syringe, but I put my finger on the opening? So I'm putting my finger here and I'm pulling this open. What would you expect my finger to feel?
The suction.
Yeah, there's going to be some sort of suction or vacuum pulling my finger into the syringe. That's applying this concept that we've just learned. So the question is why do I feel this pulling or suction? If you're going to apply the things we learned.
Pressure is increasing.
The pressure where?
Inside, so you're pulling. So the pressure inside.
So if I'm pulling this, what am I doing to the volume of the inside of the syringe?
You're increasing.
I'm increasing the volume. So what's happening to the pressure?
It's decreasing.
It's decreasing. The pressure in the syringe is decreasing. Then why do I feel a pull on my finger?
Because since the pressure in there's less, gases go from high to low. It's high outside, so it's actually kind of creating like almost this, that's what, that difference is, that suction.
Exactly. Okay, so I'm getting this syringe, the volume is increasing, the pressure is low in the syringe. But outside the syringe in the atmosphere, this is a higher pressure. So the atmospheric pressure wants to run into the syringe to equalize it, but my finger is in the way. So that's what the suction that I'm feeling is, the atmosphere trying to push air into the syringe, but my finger is in the way. So like we said, we're going from high pressure out here to a lower pressure when we decrease the pressure by increasing the volume inside of the syringe. So that's why we're feeling a suction. Okay, so as a review, I want everyone to get these down really well. What are the two main concepts of gas that we've discussed, so that the next part of this is super easy?
We talked about the
Pressure.
Okay, what about pressure, Mr. S?
The Boyle's law, the pressure of the volume is higher, and the pressure decreases.
Yes, so if volume increases, pressure decreases. So it's an inverse relationship between volume and pressure, perfect. And then Landon, what was the other one?
kind of like the diffusion of a gas that is concentration dependent.
Yeah, so if there's a high pressure gas, it will go down a diffusion concentration gradient to a lower pressure. So it wants to go from high pressure to low pressure, just like the high pressure outside of the syringe going into a lower pressure inside the syringe. Okay, good job. So now we can take all of this knowledge and we're going to apply it to what's called the respiratory cycle. The respiratory cycle. The respiratory cycle is simply your one inhalation plus one expiration. So just taking a deep breath in and out. So do it with me. Okay, we just completed a respiratory cycle. Now, in order to see how the lungs actually fill up, how do we actually make this happen? Because a lot of people think our lungs are actually what's making us breathe, and that's not true. It's actually a pressure differential that our body is creating. So what we're going to do is we're going to compare the atmospheric pressure, which just is like a fancy way of saying the outside air pressure, and we're going to compare it to the pressure in the pleural cavity. What does the word pleura refer to? What's the root word, students? And my students here.
Many.
Plural is like the cat.
Plural is many, so it's really good. In the root word for medicine of pleura. Simple.
Yeah, I'm thinking the like pleural tissue, visceral pleura. The pleura is like the covering.
Pleura refers to lungs. The visceral and the parietal refer to tissues. So pleura is just like a lung tissue. Pleura is just the root for lung tissue. So pleural cavity is just the lung cavity. That's all we're talking about when we say pleural cavity. So we're going to start by talking about inhalation. So we'll begin with the atmospheric pressure is 760 millimeters of mercury. But if we're doing a comparison, we can just set it as 0 and compare it to the internal part, the internal cavity. I put both numbers so you can use whichever one is better in your brain to compare the numbers inside and outside the cavity. So in inhalation, we know that something happens. What happens is the diaphragm, this muscle that goes up into our lungs when it's relaxed, when we inhale, the diaphragm goes down when it contracts, almost like into a U shape. So the diaphragm is going to go down, and the intercostal muscles, the muscles in between each of our ribs, are going to contract as well, and they're going to push up and out. So the diaphragm is going to go down, and the intercostal muscles are going to go up and out. What does this do to the volume of the pleural cavity? What do you think, Mr. S?
If the volume's going up, it reduces the pressure.
See, you're even getting ahead of me. You're already on it. If my diaphragm is going down and my intercostals are going up, it's easy to see the volume is going to increase. This pleural cavity is going to get bigger because there's more space. So as the volume of the pleural cavity increases, Mr. S is already even getting there, what does it do to the pressure in the pleural cavity? If my volume increases, goes up, what happens to the pressure? Yeah, exactly. It goes down. The pressure in my pleural cavity will go down. So outside in the atmosphere, the pressure of the air is 0 in comparison to the pleural cavity, which is -6 less than the outside. So outside it's really 760, and inside it's 754. So if the atmospheric pressure is 760, and the inside of my lung cavity is 754, which way will the air want to flow? It'll want to go into your lungs. Why? Why will the air want to go into your lungs?
It's a high pressure system and a low pressure system, and gases go from a high pressure system to a low pressure system.
Exactly. Because we want to go from a high pressure, 70-60, to a low pressure, 754. Do you see that inside the pleural cavity is 6 degrees of pressure less than the outside air? So what our diaphragm is really doing by increasing that volume is it's making a pressure difference so that air naturally just wants to flow into our lungs. That's how we fill our lungs with air. So now with knowing that, take a deep breath in. That's exactly how our body gets air into our lungs, by making that pressure difference. Air wants to flow into the lungs, like Landon said, from high pressure on the outside to low pressure on the inside. Now, does the increase of volume? Oh, we already had that. Sorry. That was a mistake slide. Okay, so now we know how inhalation works. How do we get air into our lungs? Now we're just going to reverse this process, so this may be a little bit easier. Exhalation. When we exhale, our diaphragm relaxes and pushes back upward into the relaxed state at the dome. And the intercostal muscles relax, so they relax inward as well. What does this do to the volume of our pleural cavity? Decreases the volume, exactly. So it brings it back. So we were big before, and now as those muscles relax, it goes back down. So as we decrease the volume or the size of that cavity, what do we do to the pressure in the cavity? Yeah, it goes up. We increase the pressure. We crank it up. As we decrease the size of the pleural cavity, the pressure goes up. And it actually goes up above 1 to 10 degrees above the atmospheric pressure or the air pressure. So now we've just reversed what we did before. Now we have a higher pressure in our lungs than is outside the body. So where will air want to flow?
Back in. Or as we expel it out.
It wants to go out because we have a high pressure inside the lungs and a low pressure outside. So because of that, the air wants to flow out because it's going from an area of high concentration or high pressure to low pressure out in the atmosphere. Exactly. So that is how we learn to breathe. That's how breathing works. We're just essentially expanding our pleural cavity, which decreases pressure and brings all the air in. And then when we make that cavity smaller, we're increasing the pressure, which pushes the air outwards. Now, there's a few cool terms that I want you to learn in relation to this mechanism of breathing. And it's 4 terms total. But you're going to want to write down the numbers of milliliters of this air coming in and out. So, Landon, do you have a pen? You want to grab that whiteboard right there? So the first concept is tidal volume. Tidal volume. Some people call it resting tidal volume. Now this just refers to the amount or the volume of air that moves in and out of your lungs during a resting respiratory cycle. So Mr. S, do you remember what a respiratory cycle is? What's a respiratory cycle?
Inhalation and exhaling.
Exactly, just breathing in and out. That's a respiratory cycle. So our tidal volume is the amount of air that comes in and out during a breath in and out. And that amount is 500 milliliters of air. 500 milliliters of air. Now doctors can test our tidal volume with something called spirometry, and they'll test this to see, hey, is someone's lungs working properly? Because if the number is like 200, it's like, oh no, they're not getting enough air in and out, so something wrong is going on. So this could cause us to be like, oh, do they have asthma? Do they have a malady called COPD? And you could diagnose it by just looking at their tidal volume. So tidal volume is the first concept. Next, our next concept is, oh, here's a question. If our tidal volume, just breathing in and out, is 500 milliliters, then how much air do you think the entire capacity of the lungs is? Like, what's just your guess? If just a breath in and out is 500 milliliters, how much air do you think a lung can hold? What's your guess? We'll see how close you get.
I would say you could double it.
Double, so 1,000 milliliters of air.
If I was going to guess.
Yeah, okay, what do you think, Landon?
I think it's 5 liters. It's 4 liters maybe.
5 liters, so like 5,000 milliliters?
Yeah, it's like 4 or 5 liters.
Okay, so Landon thinks 5,000 milliliters. Mr. Shapinsky's guessing 1,000. What do you guys guess? You can pause it and see. Okay, continuing on. Real quickly, I want to start showing us what these different volumes are and the way they fill the lung. So we have our tidal volume, that's 500 milliliters. And that will, if we breathe in, this fills up this much of the lung. Our next concept is called inspiratory reserve volume, or IRV. So if you have a reserve, like you can think of reserves in the military, it's like extra people that you can pull from. So in the same way, inspiratory reserve volume, it'd be like, I tell you to take a breath in, so just take a regular breath in, and then hold it. And then I say, take a little bit more in, try it right now. So, like you can actually get more in than your regular breath. And that's the IRV. It's the volume of air that can be inhaled at the end of a resting inspiration. So after you already take a normal breath, you can actually add more, even more, and that's the IRV. And that's the total amount that you can really inspire into your lungs. Now that additional amount that you're breathing in past just a normal breath in, is 3,000 additional milliliters. So you can breathe in a lot more when you're like trying to fill your entire lungs up than if you just do on a regular breath. So the tidal volume and the inspiratory reserve volume, that's the total amount that you can breathe in. So how many milliliters is that total?
3,500.
3,500. That's the total amount that we can inspire. Now, we also have something called expiratory reserve volume, really similar to the other one. So if we just take a normal breath in and out, but I told you breathe out more, and you go, like, oh crap, I'm sick, so that was hard. But you can breathe out more, there's more in there. So after you expire the normal amount that we just talked about, 3,500, there is still even more left that you can breathe out. That's the expiratory reserve volume, the ERV. You can breathe out more. That's the volume of air that can be exhaled at the end of an expiration. And that is 1,100 milliliters. So we have 3,500 and then 1,100 milliliters in addition. Now, the last concept is called residual volume. Residual volume is, if I told you to breathe all the way out, try this out, as hard as you can, as much air as you can let out. Try to breathe all of your air out. Okay, I tried to breathe all my air out. But after I try to breathe all of my air out, which is that ERV, that's this amount, I will still always have a little of air left in my lungs. And this is because we don't want our lungs to like collapse. It's a lot higher chance that a lung would collapse if we could actually get all of the air out. Think about this. Have you ever tried blowing up a water balloon? Have you guys ever tried that? Like, it's kind of hard to blow up a water balloon or just a regular balloon. Like, starting the balloon is like the hardest part, right? But if you start blowing it up and you like leave it and you took it out of your mouth and then you put it back on your mouth, it would be easier to then add air because it already has air in it. Does that make sense? But if you let all of the air out and restarted, it would be a lot more difficult. So that's the same concept. Our lungs actually leave this volume of air, 1,200 milliliters of air in our lungs at any given time, so that it's easier just to refill it, big and small. Also, another thing is it allows you to have continual gas exchange. So even when we're breathing out, we still have this amount of air in our lungs. So our alveoli can keep exchanging oxygen and carbon dioxide even when we're not breathing in. So we can have continual gas exchange. So whoever can add up the TV, IRV, ERV, and RV to get our total lung capacity first gets a piece of candy. Can you do it? You already have it, Mr. S?
5,800.
5,800, he already got it. He anticipated it. Let's go. So, Mr. S, for real, you can get a piece of candy. Check this out. Would you like one? Let's go. He picked Hershey's dark chocolate. Great choice. All right. 5,800 milliliters is our total capacity for our lung volume. Our total lung volume. That's the amount that one lung can hold. So, our final thing of our lecture today, our last few slides, is this. So now that we know how our mechanism of breathing works, how we actually get air in and out, and how much a lung can hold in milliliters, what its capacity is, the last question we need to answer is, how does the alveoli exchange oxygen and carbon dioxide into our blood? So yeah, we have air on the outside, but how does that actually get into our bloodstream? So, I have a question for you. Which gas makes up the majority of our atmosphere? Do you guys know?
Nitrogen.
Nitrogen is correct. Do you guys know any other gases that are in our atmosphere that make up a good amount?
Oxygen.
Oxygen, yes.
CO2.
Carbon dioxide, yes. Okay, so we have nitrogen, which is the majority, 78%. We have oxygen, like you said, Mr. S, 21%. Carbon dioxide, and then we have other gases, the majority of those being argon. And so what we're going to talk about is this whole lecture, we've been talking about pressure differences, right? That's how we get air into our lungs. And actually, our body, when it does gas exchange, it's super similar to the process of how we get air in our lungs, but it's a new concept, just like a little bit different, and it's called partial pressure. Partial pressure. Now, partial pressure is denoted P and then a little a on the bottom. Now, the way I can explain partial pressure to you is up until this point in the lecture, we've been explaining pressure, and it's been in relation to all the gases total. Now, in partial pressure, it's the same thing, the same concept, the same forces, but we're just going to focus on one particular gas. So if I'm saying, I want to focus on the pressure of a particular gas instead of all the gases, we call that partial pressure. So for example, if I was like, hey, I want to just focus on the pressure of oxygen in this area, we call that the partial pressure of oxygen. And we denote it like this if we're talking about arterial partial pressure of oxygen. Or in a generic sense, we just put P little subscript O2 in a generic way across the board. So we're going to be using it like this, PO2. That's how we're going to denote the partial pressure of oxygen. So the first thing that we do to exchange gas in the alveoli is we inhale. So we've already learned all about that. We don't need a review. When we inhale, oxygen enters our alveoli, right? Because it makes up 20% of that atmospheric air that we're breathing in. Then, the partial pressure of oxygen in our alveoli is 104 millimeters per mercury. So 104 pressure in the alveoli, in that thing that's blowing up. The partial pressure of oxygen in the alveoli, in that sac, is higher than the partial pressure in the deoxygenated lung capillary in the blood. So what's a capillary?
A vessel.
A really small blood vessel. So all around the alveoli, exactly, Mr. S, we have these really small blood vessels. And so as that alveoli, like we see here, is filling with the oxygen, and then we have all these blood vessels around it, the pressure of oxygen is higher in the alveoli, and it's lower in the blood. So what do we anticipate then happening? If the oxygen pressure is higher in the alveoli than it is in the blood, where do you expect oxygen to want to go?
To the blood.
Into the blood. Why? Because the pressure difference. We're going from high pressure of oxygen in the alveoli to low pressure in the blood. So the oxygen wants to even that out and go into the blood. So that's what it does. The oxygen diffuses across the thin wall of the alveoli and it enters into the bloodstream. Because we already talked about this, there's high pressure of O2 in the alveoli and low pressure in the blood. Then we can just reverse this same line of thinking to see how carbon dioxide gets out. So we just saw how oxygen gets in. Now we just reverse it for carbon dioxide to get out. The carbon dioxide partial pressure in the capillary is higher than the partial pressure in the alveoli sac itself. So if it's higher in the blood than in the alveoli, which way will carbon dioxide want to travel?
Let's go into the alveoli.
It wants to go into the alveoli. It want to go from the blood to the alveoli because this is high pressure, this is low pressure. So the oxygen will escape the blood, go into the alveoli, and diffuse across, just like the oxygen diffused across. And finally, the last step is we just exhale the carbon dioxide out because we just filled that alveolar sac with carbon dioxide. So this is how we exchange gas in the alveoli. So we're bringing oxygen in as we inhale. The increase of oxygen in that alveoli, the pressure is higher than in the blood, so the oxygen wants to go in the blood. In the blood, then the carbon dioxide has higher pressure, so it wants to go back out into the lower pressure alveoli, and we can breathe it out. So that's how we exchange gas, and that's the mechanism of breathing. Thank you so much for joining me today in this lecture. Okay, so now you're gonna do your patient presentation by Landon, and he's gonna propose a problem to you about some of the respiratory physiology. So please welcome him up.
Hey class, it's Landon, Mrs. Cose's husband. I'm going to talk to you today about patient presentation off of the respiratory physiology that you just learned. So that's a very important lecture because obviously everyone needs to breathe and there's a lot involved with that. So also I found these up here, so I'll be handing these at random throughout. So that was a mistake, whoever left those up there. But so say you have a patient who presents to your clinic, they're in their 70s, they have a they present with shortness of breath, and they have a, let's say, 50-year PAC history. And just a quick aside, we were talking about someone's smoking history, which is very important. You do like pack a day is kind of you do it. So they have they smoked a pack a day for like 5 years. They have five-year pack history.
Oh dang, so that's what you mean by 50-year pack history?
Yeah.
So for 50 years they had a pack a day?
Yeah, and that's kind of
Oh my gosh, whoa.
Yeah, I've seen people who smoke like 4 packs a day and get the cheap like Cheyennes and stuff, but don't smoke. Not
How much is a pack of cigarettes?
Oh, I don't know.
That's crazy. Okay, keep going, sorry.
I don't like cigars really. Anyways, so you get this patient who's in there and they have shortness of breath, difficulty breathing, and they're talking to you, you're the physician, it's like a family med clinic, we'll say that. And so you take their vitals, and their O2 sat is like 92%. And so, actually I'll explain that after. But their O2 stat is 92%, respiration rate is 19, blood pressure and temp is normal. And you want to check for, take a patient history, they have the smoking history, so you're thinking, oh, okay, this is probably a pulmonary related illness with smoking. And so you get something called, you do a spirometry exam, which is, as Ms. Cose talked about, checking their kind of lung function. And what you do is get something called a forced expiratory maximum. So the maximum you can exhale, like, and it's a 5-second period. And so what you look at is something called the forced expiratory volume in 1 second. So in that 5 seconds, it's like 80 or something % of the air you exhale occurs in the first second. And so you do that and you notice that it's greatly reduced from normal. So my question to you is, you guys will look this up, but what is the most likely disease process going on? And then 2, what is the most likely complication? And then throw in one more thing, someone at the clinic gave them oxygen and they pass out. And then so my third question would be, why would giving someone oxygen who needs it, why would that cause them to not respond well? So,
Oh, that's cool.
take however long you need to look those up and then I'll explain.
I like that one.
Okay, welcome back. So this patient is presenting with COPD, or chronic obstructive pulmonary disease. And so COPD is essentially 2 distinct disease processes going on that can be either at the same time or one or the other. And that's bronchitis and emphysema. Bronchitis, bronchioles, inflamed bronchioles, is an inflammatory process most commonly caused by smoking. There's a lot of carcinogens, there's a lot of...
What's a carcinogen?
So is like is like a metabolite or a substance that causes DNA damage and can lead to cancer, essentially. And so the worst part of like a cigarette is not the nicotine. Nicotine makes it addictive, but it's all the other like black tar and materials in the cigarette smoke. And so also just a reference of all the things to smoke, marijuana is the worst, followed by cigarettes and cigars.
Why is marijuana
Actually,
the worst?
Vaping and marijuana are the worst, followed by cigarettes and cigars. So marijuana is the worst, arguably the worst, because you get the same detrimental effects of the smoke, plus, especially in men, it increases the risk of schizophrenia.
Oh.
So there's an increased risk of schizophrenia with marijuana that they're finding. And vaping is essentially like smoking fiberglass. Vaping is worse than smoking cigarettes.
Wait, why is it
so
smoking?
No one should smoke cigarettes, but like of all those, don't do vaping or marijuana.
Wait, why is vaping fiberglass going into your...
So vaping, when you make something a gas, you change the property of how it interacts with the tissue. So they're taking these kind of like flavors and adding things on. So that's why I think it was Jubal got sued in, I forgot whenever. But vaping is, yeah, I forgot the substance. But it's like worse than smoking. But you're not seeing anything of it yet in terms of like all the detrimental effects, because it's more
It's new.
Yeah, it's newer, but it's still like, I think it'd be arguably worse than cigarettes, but all are bad, don't smoke. So where was I before that? I was talking about smoke. Anyway, smoking causing bronchitis. So bronchitis essentially causes inflammation of the bronchioles. What happens with that is you increase the mucus production because you're trying to get the irritants out of the lungs. What that does is cause a blockage behind the bronchioles. So you got bronchioles and then the alveoli. Now, the gas in the air in the alveoli cannot get out because there's blockage. So essentially, with COPD, what you get is called, there's obstructive and restrictive lung disease. Obstructive is, I can't blow the air out. I'm obstructed from blowing it out because there's all these blockages. Emphysema is damage to the alveoli, so you can't blow the air out from the alveoli. So that would be like trying to blow air out of a plastic bag. It's like you're not getting any pressure out of that. So that can be from damage to caustic tube.
Okay, so both of them are having problems getting the air out. It's not getting the air in, that's the problem.
Which is why it's an obstructive pulmonary disease. So the treatment for that is smoking cessation, and then if it's too low in O2 sat, they need oxygen, and then you would give them like steroids, inhalant to like help with the inflammation. So why would you pass? What was my other second question you asked?
I think you answered those questions, but it was the patient getting the oxygen.
Okay. So what happens when you can't blow air out is that CO2 builds up. CO2 in the blood lowers the pH. Your inspiratory drive is done in the medulla oblongata. So blood, when it passes through the medulla oblongata, neurons in the medulla are checking the pH. A low pH caused by high CO2 in the blood is going to tell you, hey, we have a lot of CO2 buildup, you need to take a breath or breathe out. And so your drive, so like if you even hold your breath, you'll kind of like feel like a push to like even breathe out a little bit, which you'll do underwater when you're holding your breath. And that's because the CO2 builds up. So you don't need breath, you have oxygen, but it's the CO2. So that's a lot of the panicking that comes with like holding your breath is from that CO2 buildup. And so when you're taking someone's like O2 stat, it's like, oh, their O2 saturation is 99%. Your tissue does not get oxygen from the oxygen in the blood. It's the oxygen that's attached to the hemoglobin. So of all the oxygen in in your blood, it's mostly attached to hemoglobin, but it's like 0.00 or point whatever percent is diffused in the blood, like bubbles in like soda. And so CO2 can't get out. Respiratory drive is determined in the brainstem, which is also in the side when you're determining someone's like if someone's brain dead or not in like a coma. Cranial nerves and respiratory drive are key indicators because they have no reflexes and they can't breathe on their own and they have no brainstem activity. So it's all determined in the brainstem. So that's why with COPD, if you overcorrect and give them too much oxygen, now they don't have the CO2 that's telling them to take a breath. So your brain isn't going to like breathe, tell you to breathe essentially if you don't have the CO2 level. So you have to be careful when you correct the oxygen deprivation in some of the COPD if it's severe enough, because they're so used to the high CO2 levels in the blood telling the medulla breathe, that you take that away. So that is, let me think if there's anything else.
Wait, why did the person pass out?
Because they got, their oxygen was corrected, but their inspiratory drive essentially was like not shut off, but like wasn't going because they didn't have the CO2 telling them to take a breath.
Wait, okay, let me try to understand this.
Yeah.
So they're given oxygen.
Yeah.
And why?
They're gonna stop breathing essentially.
Why was there not the CO2?
So it's the concentration of CO2. It's almost like you build up a tolerance for something. The tolerance that your brain builds up when it has too much CO2 is like really increased. So when you decrease it back to what a normal thing is, you're so tolerant of it that's not enough to stimulate the nerve.
Okay, so like with someone with COPD, because they can't breathe out all the way, they increase their tolerance to CO2 in the blood?
Over time, yes, the neurons in the medulla
We'll just get used to a higher...
The concentration needed to stimulate the neuron is increased.
Okay.
Because it's like...
Yeah, we'll have a higher tolerance to CO2 from our medulla.
But that's
so
when
then
it needs that concentration, though, to then stimulate the
yeah,
neuron.
so then if we supplement with oxygen, and now we have lower CO2 in the blood,
Then
back
it's
to
not-
normal,
Yep.
then our brain won't tell us to breathe out. So the person just didn't breathe out, didn't breathe because they didn't have the stimulation. Okay, cool. That
And
makes
that's like
sense.
an extreme case. But that is essentially, that's just a good example of like what's going on.
Nice, that's cool.
And then also, we're going to talk to them about metabolic acidosis and stuff like that.
I think that was really good, baby, what you just did.
Okay, well then that's it for today.
Woohoo! Yeah!